A beautiful Saturday afternoon. Thank you all for joining. This is our first Zoom general meeting, I think. We are expanding into the new technology. Can you hear me okay?
Yep.
Yes.
Yes.
Okay. So expanding in new technology in these times, you should never waste a perfectly good crisis. So we are using this as an opportunity, our stay in shelter and our phase one of re-entering kind of normal life. But we're going to continue these meetings. We met with the executive committee. I met with the executive committee um, first Monday in this month, and it was decided unanimously that despite being able to meet face to face, that they were all pretty comfortable meeting this way. And we will revisit going back to face meetings in August. So we will see how it turns out. We appreciate a our governor phasing us back into normal life, but we're going to wait this out. We have been able to meet and do some advocacy work virtually, and so we're going to continue to do that. I want to thank. We have some special guests that are going to be speaking here today. I want you to know that you can ask questions through the chat function at the bottom of your screen. But two of the things that I really wanted to deal with today was an update on what uh, COVID-19 looks like across the county, what kind of precautions are taking place, and so we can get actual information from people who are in the know so that we can be better informed advocates. So to that extent, we have Stacie Saunders on from the the director of the health department. Hi, Stacie. And we have Rebecca Rosso, who is environmental health, also at the environmental health, also at the health department. Hi, Rebecca. Hi, Becky. You there? Okay. And I also wanted us to talk about grief. We have had a lot of passings in this community, some COVID related, some not COVID related, but because we our traditional ways of going through the grief process has been hampered, we reached out to, with the help of Dr. Yarborough, reached out to Vondra Hayes Jones, who is a facilitator at Grief Share at Ebenezer Baptist Church. Are you there, Vondra? Okay, so this may be shorter than we think, but I wanted to also mention Ahmaud Arbery. Uh, keep his family in prayers, and we are continuing to monitor this situation. I think they've had some arrests, but we're joining nationwide in a call to have the district attorneys removed in that case. This There were 2 months before there was an arrest. This incident, he was killed actually on February 23rd, I think, and the arrests were just made this week. And apparently the newest information is that he had been in a vacant house, but he apparently went in to get a drink of water on his run. And that house has had lots of people in and out of it while it was being built. And these folks just took the law into their own hands. We will have time at the end of this meeting for any community announcements. So if you're part of an organization, a partnering organization that needs to make announcements, you can do so after this meeting. At the end of this meeting. Our feeding program is still going on. I think we served about 60 people last week on Mother's Day. It was a little down. We usually serve between 70 and 80 people. But many thanks to the mosque, who still is preparing food on the second Sunday, and the Burlington Alamance Association of Educators had folks who took time away from tutoring their own children and instructing their own children, and away from instructing students would have been in their classes came over and helped serve the food along with members of the NAACP. So I appreciate, and many thanks to Ernestine, who, like I said before, when I asked her if we needed to put a pin in this program, she said in true Ernestine Ward style, Mr. Brown, we got to do what we got to do. These folks need us. And so we continue to do that. Mr. Royster is continuing to drive the van. And we are not having dine-in service. We're preparing the plates and then passing them out from the porch. Mr. Royster is delivering some of those plates too. So without any further ado, we have Stacie. Did I get everything, Natalia? Anything I missed? You're muted, but I see your head going.
Yep, I think we're good.
Okay, so without any further ado, we have Stacie Saunders, who's the health director at Alamance County, and she's going to talk to us about overall what's been going on, what our status is, and then we have, if you'd like to ask some questions, she's available to answer those questions.
Okay, I can get started. And so I'll start with just the general landscape of COVID-19 in Alamance County, and then talk to, because I know you all had some specific questions that were sent to us too about what is it like to be identified as a case, and what is that process, and then how does someone, if they're exhibiting symptoms and either don't have a medical home or are uninsured, how does one start to access these systems so that they can receive be collected, get a specimen collected for testing. And then my partner, Becky, from the health department, will go over specifics around how we do the wraparound services for those who are food and housing insecure through this process of isolation and quarantine. And so if Becky could be muted about, probably now would be good just in case. I'll just get started then. So as of today, we identified our very first case of COVID-19 in Alamance County on March 20th. And since then, we've had 214 cases confirmed here in Alamance County. That's a cumulative total from March 20th until now. Of those total confirmed cases, 114 have been released from isolation. That's slightly different than a definition would be for recovered. Release from isolation means that they are no longer being monitored by the health department, and they've reached the criteria that allows us to say we don't have to check in with you daily anymore. And that criteria currently is at least a minimum of 10 days since the onset of symptoms, and that symptoms have to be improving, and that an addition, and 72 hours with no fever or increase of symptoms. So if you make it to day 10, and then all of a sudden you get a fever or your cough gets worse, you can't come out of isolation. So if you make it, to day 14 post onset of symptoms, and your symptoms are improving and you haven't had a fever and things are looking good for you, and you've been 72 hours without any type of fever or increase in symptoms, then we can start thinking about taking you out of isolation. And so recovery is a little different than that, and there's not a very good definition about recovery right now, because that could take quite a while for someone to go back to feeling normal or pre-COVID, right? So you might have a residual cough for a while, you might have some fatigue for a while, and so that recovery rate is very subjective versus the release from isolation, which is based on some concrete criteria. Also included in that 214 confirmed cases are 89 cases that remain active and in isolation. So this means that there are 89 people that we are actively monitoring each and every day for any change in their symptoms, for hopefully improvement in their symptoms, and any other issues that they're having during their isolation that need us to help them get resources or medical care or anything else. And included in those active cases, so included in those 89 active cases, there are 21 of our cases who are seeking care at a hospital right now. So that means that their symptoms increased to the point where they needed medical intervention and that they couldn't convalesce and recover at home on their own. And then of those 214 cases, sadly, we have experienced 11 COVID-related deaths in our community. 3 of those deaths have been in the general population, and 8 of them are related to a long-term care facility outbreak. And so a lot of your questions that were sent to us ahead of time centered around what's the process for all of this. And so what I'll do is talk about the process and then talk to you a little bit about how does one get collected and what resources are out there for folks. So when someone has a specimen that's collected and it's sent off to the lab and they test positive, there are already public health laws that have been in place for many, many years for reportable diseases. COVID-19 was put on the reportable disease list several months ago. And when a test comes back positive, it is automatically sent to the local health department of that person's residence for the health department to then start follow-up. And so not only is it sent to the state, it's sent to us. And so we call the individual immediately. So usually that's first thing in the morning when we come in and we see what has come into our workflow that day. And so we give them a call. We start talking through with them about their onset of symptoms. What day did that start? When did they get tested? How are they currently feeling? If they have medical care, who is their medical provider? We start talking through who lives in the house with them and any other close contacts. So one of the biggest things that we have to do is identify any close contacts that this case has had during their infectious period. And so typically our criteria now for the infectious period is 2 days, 48 hours prior to the onset of symptoms. And so we're really curious about if I started a fever on Wednesday, I want to know, the health department's going to want to know everybody I've been in contact with on Monday, Tuesday, Wednesday when I went to the doctor and got tested, got isolated, and then I need to know anybody after that time. So that's where the household contacts come in play. And so identifying each and every one of those close contacts, and then we start calls with them as well. So we have a whole team that works on this all day long. Those close contacts are then also called, and we go through their risks, and they're placed under quarantine. So the case is placed under isolation, and the contacts are placed under quarantine. And the only real difference there is isolation refers to someone who is known to have a specific illness. In this scenario, it's COVID, and so they are exhibiting symptoms. And then quarantine, it's someone who has been exposed and is at risk for developing COVID, but is asymptomatic. And so we check in every day with every close contact to see if they develop symptoms, and if they do, refer them for collection, and then they go into isolation as a presumed COVID positive until we get that test back that tells us whether it's positive or negative. And so we also do a lot around what we call wraparound services, so those support services, and Becky's going to talk a little bit more about those, but I wanted to go into a little bit of how does one get collected in our community. And so for several weeks, collection for COVID was pretty sparse for lots of different reasons. You know, for testing in very early days, our large testing facilities, so that would be things like the state lab for public health, or LabCorp, or Quest, very large testing facilities didn't have what's called a reagent to successfully do the test. And so they may have had the capacity and the workforce to do it, but they were missing a really key ingredient to make the test work correctly. And so that gets worked out, and then we started to see some supply chain issues around what's called an MP swab. So the collection method for this particular test requires a nasopharyngeal swab, which literally goes, so if you think about just the very top part of the very opening of your nose and your nostrils, that's just a nasal area. We actually have to go in that nasal area and all the way back into your pharynx part of your body. So that I just saw some people wince. Yeah, it's not pleasant, but it takes a very special swab to do that. And so in the supply chain issues, that swab was really hard to come by for a little while. And so as testing facilities got their capacity back when they got that reagent, then we started seeing providers having issues with getting the actual MP swab to do it. Much of that has been worked out. What remains to be sometimes a bit precarious are the PPE, and that's personal protective equipment that's needed for, say, a health department nurse to then collect that. Because if you're collecting someone for COVID, that means they have enough symptoms to make you think that they probably have it. And if that's true, then you have to protect yourself from getting the pathogen yourself. And so that requires a great deal of what we call PPE, that personal protective equipment. And depending on the provider, that still sometimes can be some hard stuff to get. So there are special N95 respirators that filter out lots of those tiny, tiny things that we can't see. And that's one of the things that we must have in order to collect, because when you stick that MP swab into someone's nasal cavity, it's likely that they're going to aspirate a little bit, or they're going to have some stuff come out into the air. And so you want to make sure that you're protecting folks with an N95. In addition to that, it requires not only an N95, but a face mask, goggles, if the face mask is not readily available, and sometimes both, a gown, footies, gloves, and then the N95. So it's quite a bit of stuff that somebody has to wear in order to get that. And so as more and more providers started getting more of their PPE back, we saw some of that access to collection open up. So I'm happy to report that we have several sites here in Alamance County that are collecting. And the criteria for each one of them to collect vary slightly, and the populations that they're reaching vary slightly. And so the health department has the capacity to collect and has collected about 800 specimens for testing thus far. We tend to focus right now on those long-term care facilities. So while we have other providers in the community who are collecting, we're trying really hard to make sure that we don't have any more outbreaks in a long-term care facility. So much of our efforts around collection have been anytime that a long-term care facility has a case or starts to have 2 cases, we deploy our entire nursing collection staff to the facility to test all of their residents and all of their staff. So you can imagine most facilities have 100+ staff. Many of them have close to 200. And then most of them have, I think the smallest we've done so far was just the 80, they had 80 or 90 residents. And so many of them have much more than that as well. So that's a pretty daunting task. But the health department is also able to collect, and we actually partner. We can collect within our own facility, but we also partner with our hospital who just opened their collection site at Grand Oaks on May 13th. And the criteria that we're using for that referral is typically the high risk, high priority. So if you're over 65, if you have an underlying health condition and you're having symptoms, you're going to be likely to be eligible. And you can call the health department and say, hey, I'm having symptoms and I don't know if I meet the criteria, but I sure would like to maybe get a test. And so what we'll do is do the screening and the assessment for that individual. And if they meet the criteria that we can send them to Grand Oaks, then we'll do that. And if there are any barriers to that, then we're happy to do it ourselves. And guidance just changed the other day that now uninsured with symptoms can be sent straight to the state lab. That was a huge breakthrough for us at the health department, because we're able to send to the state lab, and that doesn't actually, although it has cost to us, it doesn't have cost to the individual, which is great. In addition to the health department and Grand Oaks, Piedmont Health Services, which has several locations within this area and many in Alamance, is actually doing collection as well. Now they require an assessment through one of their providers, but it can happen at any one of the sites, the assessment, and then they work to get an appointment at a fixed site collection site in Burlington at the Burlington Community Center, which is located on Vaughn Road, not far from where the health department is. And so Piedmont Health Services does serve the underinsured, the uninsured, and vulnerable populations, much like the health department does. And so they're doing collection with almost like a drive-through. It's out in the parking lot. So they're able to do that as well. We actually formalized an agreement between the health department and Piedmont Health Services just this week, because our health department doesn't actually do adult primary care. And so once someone is in isolation as a case or in quarantine as a close contact, the health department follows up with them every day. But if they have some other health issue, say not related to their COVID, but some other health issue, we're not able to help them with that. And so we have formalized an agreement with Piedmont Health Services that if we find a case or a contact who has no medical home, no documented medical home, that Piedmont Health Services will become their medical home as long as the case and contact agrees to that. So that, that we ask their permission and their release of that. And then after their time in isolation and quarantine, then Piedmont Health Services becomes their medical home. They're out. And then in addition to Piedmont Health Services, Coronado Clinic Walk-In is also doing a collection of tests. And in the beginning, they were doing it for their existing patient population, but they've opened up theirs a little bit as well. And then there are several, there are lots of things that are coming down are expected in the future. Urgent cares are coming on now that supplies are a little bit more readily available. FastMed in Burlington will do it if they need to do it, but they prefer folks to go to their site in Greensboro, which has more capacity. And as the state has set their vision for more testing opportunities, it's likely that we're going to see some of that in our community too. We're working with our hospital partner and our our federally qualified health center partner, which is Piedmont Health Services, to identify also mobile collection, which is, it's great to have these fixed sites, but if you had limited access to transportation prior to COVID, you probably still have it. You probably still have limited access to transportation. So how do we mobilize this collection to communities that need it? And so that's coming. That requires a bit more resources, which means more stuff and more dollars to do that. But most certainly working with our partners and also leveraging some of the partnerships that we've had as the hospital and the health department in the past with our community partners. And so more to come on that. We're working really hard. I just presented to a group at the hospital with the hospital partner that was solely dedicated to how do we mobilize collection. So fingers crossed that's going to happen very soon. I think that's about it for collection. So Becky, do you want to talk a little bit about how we identify with our cases and contacts if there's food and housing insecurity and what we do from there, and how we work with not only our health department staff, but our community partners?
Sure. So
What I'll start off and then kind of explain how we kind of started getting into the more wraparound service stuff. So early on in the COVID response, Stacie recognized the need to start planning for the housing insecure and the homeless. So we formed a collaborative work group, of which Baird is on that work group. Several of us from the health department, Cone Health, several of them, our DSS partners, our emergency management partners, some mental health partners, our shelter partners. And so we started planning for the homeless and housing insecure, and how would that look if one of them became ill and we needed to house them so they could safely isolate while they're recovering, or put them in quarantine while if they were close contact. So we started planning on that. So we came up with a great plan with the hotel, and that's been working really well. And as we moved along with that plan, we started, as the event has kind of morphed and as the outbreak has changed and grown, the needs have grown as well. And so we started to realize that while we'd planned for these wraparound services for the isolation and quarantine of someone who was homeless, which would include mental health, medical, and feeding, we realized that the definition of housing insecure changed. And so it could mean anybody who's living in a home that's overcrowded, or a home that may have multiple generations living in the home. And so we want to make sure that we were protecting everybody in the home. You know, if you have somebody who's sick and is using the one bathroom in the house, you know, you want to protect the rest of those people, and that's not easy to do when you're all sharing a bathroom. So we started thinking about that need. And so that kind of changed, and the way we are planning for that has changed as well. And then we started to see that even those who are homeless or housing insecure, how they needed these items, and this change in the definition of housing insecure. We also realized that those who are isolated and quarantined, living in their house, you know, might be a single parent with several children. Well, we do not want that individual going out to the community to get food for their families. So we've started to feed these individuals as well. So if someone is in a home and they can't get out to get food, medication, any items at all, really, they can talk with their nurses, as they do every day anyway, and let their nurse know what needs they have. And so we've partnered with a couple of local restaurants, and actually the school system as well, to ensure that children are getting lunches from the school system, so they're not leaving their house to go get the lunches. We're going and getting the lunches and bringing it to their home. And then we're also ensuring a hot meal is delivered for anyone in the home if there's someone in there who's under isolation and quarantine. So they're receiving at least a hot meal every evening. We've also been working with some of our other partners like United Way, some of our church partners, and we've started our own pantry, if you want to call it that. So we've got a lot of donations, working with our emergency management partners over at the EOC. We've got lots of supplies, and so when we get the donations in, we make meal kits for families. So it's groceries that hopefully will last someone for several days. So we've been working, getting those supplies gathered up, bagging them up, and then every day we are making deliveries, anywhere from 2 deliveries to this weekend we probably were making almost 20 deliveries to different residences. So there's a need out there, and we don't want those individuals going out to the community and possibly spreading the virus to others. So we're providing those services for them.
Thanks, Becky. Yeah, so I think there were some questions too about, isolation, quarantine, and these orders. And so, public health law not only has the mandatory we shall report these diseases, but there's also bestowed upon the local health director the authorities to isolate and quarantine. And in non-pandemic times, that typically is done through an education and awareness to the case of the reportable disease around the control measures, what they need to do to make sure they don't spread their disease, and what we expect them to do about how to protect others. And then depending on the reportable disease, it outlines what their isolation period will be and lets them know that this is an order through state law, and failure to comply has ramifications. Now, it's not like a one strike and out. In non-pandemic times, we did have written documentation that was given to everyone. In pandemic times, when it is so many cases and so many close contacts, we don't necessarily do all the paperwork we don't do all the written orders. Everybody is given a verbal order from the health director via the nurses in the team about their isolation and quarantine period. And we've had folks who have been extremely compliant. Now in non-pandemic, non-COVID times, we've had onesies and twosies. I've been the health director for 5 years now, and I think I've only had 2 cases where there was gross neglect of compliance on behalf of the case, and we had to take much further efforts. But that is the exception more than it is the rule. When most people want you to be able to, want to comply, and they want to make sure that they're not going to hurt other people. And that's what we found overwhelmingly with our cases in this situation as well. They want to make sure that they're not going to potentially expose others.
Okay. Well, thank you both, Becky and Stacie. I gotta say that one of the reasons why I've gotten to know Becky a little bit is because initially when this first started, I was asking questions about how to take care of how we were providing for people who were living at the margins. And I think I called Bob, who's on the board at Allied Churches, and he said, those are good questions. I'll see if I can figure it out. And then I was calling the mayor in Burlington, and finally I called a lot of people who thought they were really good questions, and everybody was investigating. And finally, the county manager called me and he said, look, you got a lot of good questions, and so we might as well join this task force so you can talk to people who are actually making these decisions. So I was glad to be invited to join that task force. And Becky and Stacie are doing heroic work in this community. Many thanks. I'm going to open it up for questions. Anybody have any questions for either Stacie or Becky?
Hey, Barrett, I'd like to make a shout out to Stacie. I was on the Board of Commissioners for 4 years, and during that time, Stacie was first our interim director, health director, and then the board saw fit, and you can see why, to appoint her in the permanent position. But I was on the Board of Health for those 4 years, and then I also served on the North Carolina Local Health Department Accreditation Board for 3 years. And so I'm saying that because I know I've met health directors all over the state, and I've seen their work, and I've seen Stacie's work, and I can tell you without a doubt, Alamance County is so very lucky to have her as our health director. She is really one of the best, and she's well regarded across the state. So I just wanted to say that.
Thank you so much, Bob. I appreciate that. I can't take all the credit. It's because of folks like Becky and a whole team at the health department that we are a pretty well-oiled machine at this point, and we rely on each other quite a bit. And so I appreciate those sentiments. I do, and I'm going to try not to get blushed. But it is a lot of folks behind the scenes, and that's one of the things that, public health is sort of this invisible, one of the former state health directors called it an invisible miracle, that you rarely ever see us until something really significant happens. But we are always, even in non-pandemic times, we are always working to protect the community against threats. And so this is one of those key examples of how we rely on not only our own expertise and our staff, but also those in the community. So we're thankful for Mr. Brown's partnership and willingness to serve on these task force, because it takes a team. So I saw that there's a question.
Could you
Our
read
tracking-
the question? Yeah,
Yeah, it
read
looks-
the question for the people who are on the
Sure.
phone.
So it says, are tracking the % positive in tests just for Alamance, and how is that changing over time? I know the national average is about 20% in the beginning of April and is now down to 8. I'm wondering how we fare against the nation. So here's what I'll tell you. Locally, this is a really hard % positive to get. And I will tell you that North Carolina DHHS is tracking is tracking the total number of tests and then the cases. And so anything that becomes a confirmed case is a positive. And so if you take that positive or confirmed case and divide it over the total number of cases that the state is reporting, then you'll get a rough estimate of the % positive. At a local level, that's really hard to do, but we're getting better, and I hope there's going to be more opportunity in the future, and here's why. And it's even hard at a state level and a national level, and here's why. At a state level, I told you about those reportable diseases, right? And so the law is written that a lab or a provider shall, that means they do not have a choice, they shall report the positive test to the local health department. The law is not written that they must report the negatives. They can, but they don't have to. And so in order to get a real big picture, to get the big picture of that, we have to have the negatives as well. And so you've likely heard Secretary Cohen talk about the testing surge work group, which I am serving on, and honored to do that at the Secretary's work group. And one of the big pieces of that testing surge work group is to make sure that we're getting a better, I would love to say that we're getting all the tests collected, the number of tests collected, but my guess is, we'll get close. But one of the big tasks is to make sure that we increase the number of the negatives that are reported, and that requires testing facilities to do that. So the state lab does that, LabCorp does that, Quest came on doing that last week. But there are lots of other smaller testing facilities that are not hooked up to the state system in the same way, and that there's a bit of a delay. And so they're definitely reporting, they shall, and they are definitely reporting the positives, but they may not be reporting those negatives. So that's a really hard percentage to get. I do encourage you, I wish I had pulled it up, but I don't have it on me right now. But if you look at the North Carolina DHHS website and take the number of confirmed cases that they have over the total number of tests, you'll get a rough estimate of that. And I hope that soon in the future that we'll have a rough estimate county by county about that, but that's to be determined. Thanks, Eric, for that question.
And how do those numbers shake out by race in Alamance County?
Now I did pull that up for you. So we are reporting weekly demographics. So every week we're reporting a breakdown of cases by a few demographic indicators. One being, one of them is race and ethnicity, and one is age. And so, and the way that we set this up, so I encourage you, if you haven't seen our website yet, go to the health department's website, and there's a banner at the top just called COVID cases, or COVID case count. If you'll click on that, it'll take you to our daily case count, and right underneath our daily case count is something called weekly demographic reports, and they're updated every Monday. And so it's based on what the cumulative case count is so far, and then the demographic breakdown. So as of, this was updated May 10th, so the next one won't be until May 18th. But the way we set it up is based on the distribution of our local, of our county, and then compare that to the distribution of COVID. And so among white or Caucasian, the Alamance County total county distribution is roughly 74%. Within the COVID confirmed cases for Alamance, it's about 64%, which compared to the state is 53%. Among Black or African American, our general population distribution is about 21%. And then amongst our COVID cases, it's 27%. So you can see, compared to our general distribution in our general population, our COVID cases are slightly higher. And then amongst the state, it's 35%. So you've likely heard Dr. Cohen talk about that disparity. That, thank you. It looks like someone's pulled up the cases. Thank you. Has talked about that disparity, that when we compare, even at a state level, when we compare the distribution of COVID cases among our minority populations, it's quite higher than what we experience, what that percentage is in our general population distribution, which is why part of the testing search group that I'm working on, that I've been working on with the state, is one of the tasks is to figure, how do we figure out a way to make sure that folks get access that need access, and particularly our minority populations and our marginalized and vulnerable populations that have historically been marginalized in health issues. And so that's part of the discussion. And then with the ethnicity for Alamance County, our general population distribution for Hispanic, which is how the state, it's Hispanic and non-Hispanic, is about 12.8%, whereas amongst our COVID cases, it's about 27%. And many of those cases were associated with a meatpacking plant outbreak that happened in a neighboring county. And what we found out was that the employee population of that meatpacking plant was had a high percentage of Latinx. And so while folks worked in that county, many of them lived in neighboring counties, including ours and many others. And so we did have a few cases related to that. And then in regards to age, we mimic the state quite a bit when it comes to age. Our largest, again, this is based on sort of just the percent, and so of Alamance County, our highest group of cases in Alamance County is 25 to 49 years old, followed by those who are over 65. And just to give you some perspective, that also the state, their highest group is 25 to 49. But at the state level, the bulk of the overwhelming majority of the deaths are in folks who are over 65. And all of our deaths in Alamance have been in those who are over 65 as well. And then also on those weekly demographic reports, the state just a couple weeks ago started reporting by zip codes. So they have a map that you can target in on for zip codes to see really more granular data. But for us in particular, our highest zip code, which has about 40-some% of our cases in Alamance County, is 27217. And so that's that Burlington, Union Ridge, Pleasant Grove.
That's North Burlington?
Yeah, it's over east and north. Yep, that's exactly it. Followed by 27217, which is the Burlington zip code that's closer to West Burlington, Elon, Gibsonville. And then 27253, which is that Graham, Swepsonville, Saxby-Hall. And then 27302, which is Mebane, Hall River. And then the other zip codes, just there are about 1, 2, 3, 4, 5, about 6 other zip codes with much smaller numbers. And then also in that report is our the new cases by day EpiCurve, which the cumulative case count, it's always going to get higher because you're just adding cases every day, right? And so it's always going to be going up. When folks talk about those curves and the peaks, what you're really looking at is the new cases by day. And we want that curve to be low and slow. And so far, Alamance has been pretty low and slow. We're starting to see things increase quite a little bit now. Some due to the long-term care facility outbreaks, but also as you increase access to collection, the more you collect, the more you're going to find, right? And so no big surprises there. It's just that our case count is starting to increase, and we topped 200 just yesterday. So we were a little slow. Our neighbors all around us were seeing lots of cases pretty quickly, and we're starting to catch up at this point. But our curve still right now is kind of low and slow, and that's where we want it. That it might take longer for us to get through the course of the infectious, the pathogen, but we keep it low and slow, and so that we don't have a peak that goes like this, because that high and fast peak not only overwhelms the hospital system, but it's going to overwhelm your public health system. But low and slow, it might take a little bit longer, but it's going to keep cases at a much lower level, so not to overwhelm your hospital systems, and to allow for your public health system to do the contact tracing that it needs to do. And so let's see. Do we know the current lag time on test results from test date to report date? I have an average. Currently, for the state lab, which is run by the Department of Health and Human Services, it's about anywhere from 24 to 72 hours, depending on when the test gets there. And so clearly, they're batching tests. For LabCorp, which is the commercial lab we use, I can give you that one. It's about the same. It's usually about 48 hours, sometimes 72. So much better than it was in the beginning. So state lab has consistently been somewhere around 24 to 72 hours, depending on when it arrives. Some of our commercial labs in the state, because of some capacity issues, we were seeing turnaround times of 5 and 7 days. So by the time we were getting notified of a case, they were on their way to recovery and kind of out of, sometimes almost out of isolation at that point, which made close contacts really, really tough, because their provider, if they were being seen by a provider, the provider would have put them as a presumed COVID case and told them to isolate. But depending on how they were getting their test, they may or may not have gotten that information. So, but now I can assure you it's anywhere from 24 to 72 hours, which is a pretty good turnaround time.
Stacie, I want to give you, we have one more segment after this one, but I want to give you and Becky an opportunity to tell us, so this is going to be broadcast on our Facebook page and our YouTube page, so many more people are going to have an opportunity to see this than people who are in this meeting. But what advice do you have for citizens about how to conduct themselves, or what's the most important thing you think that we need to know before we move to the next segment?
And Barrett, I have one more question.
Okay, and another question.
Okay, so I'll start.
Let them answer that one, and then you can answer this one, Dr. Yelp. You can ask your question.
Okay, go ahead.
Dr. Yarborough, what's your question?
You want me to ask the question?
Yes, ma'am.
Okay, my question is, you reported a high number in the East and North Burlington, or in the 272 zip code. Could that be because there are a couple of nursing homes in the 27217 zip code? Because I know we have a significant number of cases over at White Oak Manor, and we did not get that information until late.
Yeah, so
could it be that it could?
So I can tell you, since we started releasing the zip code data, 27217 has been the highest, and that was slightly prior to any long-term care facility outbreak. But most certainly, the way that long-term care facility outbreak numbers are, so each outbreak at a long-term care facility is managed. And so we have our county cumulative case count, And so if there's an outbreak in a long-term care facility, any of the residents that test positive are automatically going to be counted toward our county's case count, because that's where they live. They live in this county, right? The staff may be a whole different story. So not all staff at a long-term care facility live in Alamance County. So the ones that do, and if they test positive, they'll count toward our big county case count. But if they live in a different county, they're going to count toward their home county's case count, but they will be linked to the long-term care facility outbreak through our own local health department surveillance, but also through North Carolina DHHS's surveillance report. And if you look on that website that Natalia, I think you had put it up, that there are lots of tabs, and one is called Congregate Living Facilities. And if you click on that tab, there's a bi-weekly report that comes up that is updated on Tuesdays and Fridays that show you all the long-term care facility outbreaks in the state by county. So the cases, so all that to say is that staff may or may not live in the county. And while we're tracking them here at the health department, if staff don't live in this county, they're going to be counted toward their own county's case count, but they'll be linked by us here at the health department and by the state to the outbreak that's happening at the long-term care facility. But yes, so as long-term care facilities, depending on where they are in the county, if they have an outbreak and their residents are affected, and the staff that live and the staff that live in the county, those cases will affect our case count and the distribution across the county. And so most certainly the residents who live in the facility would be counted toward that zip code where the facility is, because that's their place of residence. Were you able to find it, Natalia? If you scroll down, yeah, and then by congregate living facility, and then so you've got some data there about just the types. And if you keep going, did I miss it? Oh, go back up. I'm sorry. There you go. Keep going. Up. Right there. COVID-19 ongoing outbreaks in congregate living settings report. That's updated every Tuesday and Friday. And so you can start to see the breakdown. So if if you have family in another county, there's lots of data on the state website that you can start to look through. And then it sort of breaks it out by actual county. And so you can see our actual two. I'm sorry, my little humans just came home, so I apologize. So you can see our two long-term care facility outbreaks being White Oak Manor and Peak Resources. And Peak Resources has 2 confirmed cases in their staff right now, and an outbreak by definition is 2 or more confirmed cases in the facility, and it can be in either staff or residents and or residents. And so you can see that breakdown there.
Okay,
and
thank
so
you.
To close out, I'll answer Mr. Brown's question, which is what do you all need to know now? And so the precautions, so in the absence of a vaccine, and we're some ways away from a vaccine, in the absence of a vaccine, the precautions that we've been educating folks about are going to be the strategies that we can use. And so the governor issued a stay-at-home order, and now is in process of phasing some of those, phasing the lifting of those restrictions. And so as those restrictions get lifted, the message is going to still be around those precautions around make sure you wash your hands a lot. And when you're not, when soap and water is not available, use hand sanitizer with 60% at least of alcohol, and do it often. When you are out and about in public settings, it's important to be sure that you are keeping some distance between you and others. That's 6 feet, and there's a really big reason for that. So when we look for close contacts of a case, we're looking for not only the household contacts, but anyone that case has been in contact with for at least 10 or more minutes and within 6 feet. So keep your distance from others, and wear a mask when you're out. And that's to protect not only you, but to protect others. So you may be carrying the virus on you, and that protective covering, particularly if you sneeze or cough, is keeping that, that aerosol that you're going to create through a cough or a sneeze closer to you, because without it, that can travel. And so it's just as much as a protectant for others as it is for you. And so we talk about that a lot at the health department and make sure that that's on our social media about protecting yourself so that you can protect others. That's one of the biggest things that you can do, that it's not just about protecting you, that all these things that we're asking folks to do is also protecting our neighbors in our community.
Thank you. Becky, you got anything to add? Okay. Thank you, Stacie, and thank you, Becky. We appreciate you joining us and letting us know what it is that's going on in the county, and being able to get that information firsthand is so critical to being able to be better informed advocates. So thank you very much.
Thank you all.
Yeah. And thank you for everybody who asked questions. Again, this will be posted on Facebook and YouTube pages, so lots more people will be able to get that, but they won't get to ask questions because it'll be recorded and recast. Again,